In this video, Dr. Todd Davis shares how he uses the iTero Lumina scanner to streamline the removable denture process, improving comfort, accuracy, and efficiency for his patient.
I had an 85-year-old gentleman come to see me with a chief complaint of a loose bridge on his lower right. He had a complete maxillary denture and a mandibular partial denture with 5 remaining teeth, all with a poor or hopeless prognosis. After discussing options, he declined implant treatment and decided to proceed with extraction of his remaining dentition and fabrication of an interim lower denture. After the healing period, we started the treatment of new maxillary and mandibular dentures. I started by assessing the vertical dimension of occlusion using calipers, measuring from the interpupillary line to the lip commissure, and from the philtrum to the chin. The measurements were close, but the patient had no incisal display when smiling, and the vertical dimension of occlusion appeared slightly closed. Also, the maxillary denture showed substantial wear, so I decided to increase the VDO by just a few millimeters. My approach was to complete the border molding and the final impression first, knowing the impression material would add some vertical height. I marked the patient's nose and chin, had him bite into occlusion, and transferred those marks to a cotton tip applicator to record his existing VDO. I proceeded to apply adhesive to the existing dentures and completed border molding with PVS putty. I then applied light body PVS to the intaglio surface and seated the dentures in the patient's mouth. At this point, I guided the patient into occlusion, checking that the VDO matched the facial marks within a few millimeters. This step is critical. If the dentures aren't fully seated or the material sets prematurely, the vertical dimension can unintentionally be increased. I removed the dentures and assessed retention. Good retention here is key. It directly affects the final denture's fit. I carefully cleaned off any loose or excess PVS using a number 15 blade, making sure not to damage the patient's denture. This step is important because loose material can cause scan errors and excess PVS can alter the bite if on the occlusal surface, or mislead the design team if on the facial or lingual surfaces. With the impressions clean, I scanned both dentures using the iTero Lumina scanner. First, I scanned each denture 360 degrees outside of the mouth, then I scanned them in occlusion inside the patient's mouth to capture the bite. Optionally, I also scanned the dentureless arches. This scan is useful to have in cases with challenging anatomy. The lab can merge the denture and dentureless scans in exocad software and define which specific areas to use from the two scans. The iTero Lumina technology completely changed how feasible it is to scan dentureless, ridges, and dentures. The scans are completed effortlessly and quickly. I uploaded all scans and patient photos to the MyiTero platform, so the lab received everything through a single channel. When the order gets to the lab in a few minutes and they have the iTero-exocad connector activated, all the files go directly to their exocad software, which saves them time. Opening the orders immediately gives the opportunity for the lab technician to provide any feedback regarding the quality of the scans or any other information needed while the patient is still in the dental chair at the office. With all the necessary data, the lab creates the dentures design in exocad. In this case, where important changes are required, instead of printing the final dentures, we prefer to print try-in dentures and clinically validate the design before proceeding to the final dentures fabrication. The effort and cost of a prototype is low, so whenever in doubt, I prefer to include this step. Back in the office, the patient came in for the try-in appointment. I placed the dentures in the patient's mouth and assessed retention, stability, occlusion, vertical dimension, phonetics, and of course, aesthetics. Although the colored prototype is not mandatory to have, it helps the patient to assess the aesthetics. The fit and retention were found to be satisfactory. We proceeded with removal of minor undercuts, adjustment of the maxillary anterior extension, and occlusion on number 10. I left the articulating marks on the prototype, scanned the try-ins, and sent to the lab. Back at the lab, the technician updated the design accordingly and proceeded with 3D printing the final dentures. Modern materials offer excellent resistance, aesthetics, long-term color stability, all at a lower cost and faster turnaround time. In the third appointment, we final checked for optimal fit, function, and aesthetics and delivered the new dentures to the patient. This case shows how the iTero Lumina scanner, combined with a fully digital workflow and modern 3D printing, can deliver efficient, comfortable, and cost-effective treatment. And with the final design file saved, we can easily reprint the denture in the future if needed.